Sure. So this is a study that we initiated with the Urology Institute at the University Hospitals. Basically, we wanted to see if changing the way we think about healthcare in general and healthcare delivery more specifically would impact positively health outcome. And we chose a subject that's very, very personal and private, which is erectile dysfunction. Because we have a lot of body of evidence and data showing that people with erectile dysfunction have high risk of cardiovascular disease, like stroke, heart attack, or any vascular abnormalities. So we want to see if, based on this data that we have, can we go to the community and then partner with champions in the community and try to recruit patients where they are? So this old traditional way of waiting for patient in clinic and expecting them to show up despite all the challenges that they have, despite all the problem of transportation and financial trouble of social determinant of health, maybe we can change this attitude from a healthcare provider and then go meet the patients where they are. And this is what we did. We went in and then we first tried to educate patient about what we're trying to do. So we talked a lot about erectile dysfunction as a disease. We discussed the pathophysiology. We discussed we were here as a urologist to help improve and treat this condition. But we also explained to them that maybe through this erectile dysfunction screening, we can also detect some more serious cardiovascular disease that they have. So we included around 50 men with a standardized erectile dysfunction questionnaire. And those who are eligible, then we reach out to them, consented them, and included them in our study. And then we offered them a calcium score scan, which is a scan that's offered for free through university hospitals. And then we analyzed the data and tried to correlate their score of erectile dysfunction with their score of calcium score on the CAT scan that they had. And what we actually found is pretty amazing. The patient who had erectile dysfunction, especially the severe form, had a higher calcium score. And as we know, the calcium score is correlated with higher risk and incidence of cardiovascular diseases. So this was a very novel and interesting project whereby we took something that's already been proven, the pathophysiology and the connection between erectile dysfunction and cardiovascular risk and health is there. But then we went to the community, we established relationship and trust with this community. So mainly we partner with barbershop and with churches in East Cleveland, areas where usually we have underserved population. And then it was a very rewarding and fulfilling project, I would say the less. Great question. So we know that erectile dysfunction and cardiovascular disease share a common pathophysiology, right? So the main reason of erectile dysfunction and the most common one is a vasculogenic ED, whereby the vessels and the very small arteries and veins of the penile structure and the perineum got slowly obstructed and included with time. And these two conditions share the same risk factor. So diabetes, hypertension, history of smoking, any untreated high cholesterol and dyslipidemia. All of these risk factors would negatively affect erectile function and cardiovascular health. So, given this common risk factor and given a common pathophysiology whereby the endothelial of the coronary arteries and the endothelium of the penile arteries will slowly over time get obstructed, and once you obstruct the lumen, there's not enough blood flow to create a satisfactory erection. But this is the same pathophysiology for the coronary arteries, whereby not enough blood supply would go to the heart muscle and heart cells. So the fact that we found this relationship is proving what we already know, that erectile dysfunction is usually considered the first and earliest sign of future cardiovascular disease. So because the penile vessels are the smallest vessels in the human body. So when they can obstruct first, the next smallest vessel are the coronary vessels. So this is just a prediction, a window of the future of it happened now. There's a dysfunction in the endothelial cells. The patient has risk factor. Most likely something's going to happen with their coronary arteries. And the calcium score was just a vehicle to prove and show that. So usually any patient who comes to the urology clinic, especially nowadays, we are aware of this relationship, and we always have to take into account that this is not only a condition limited to urology, but we have to think a bit broader than that. And because usually we are the first interaction of these patients with the healthcare system, this would allow us to get them into the system, get them comfortable, establish trust, but also help coordinate and facilitate care delivery. So usually what I do personally is, first I make sure that they have a primary care who's taking care of their hypertension and diabetes and dyslipidemia. And then if there's any suspicion that these patients have these risk factor and they have the primary care, I have a very low threshold to send them to a cardiology for an assessment. I think it's a combination. This is not one answer that would solve the mystery of cardiovascular disease or ED. This is one part of the puzzle. So you have the endothelial dysfunction in the penile vessels, and this endothelial dysfunction is related to aging, to risk factor, again, like diabetes, hypertension, cholesterol, family history, smoking, obesity, or high BMI. And these are very similar to what happened to the coronary arteries dysfunction. So again, for us, it makes sense that the worse the erectile dysfunction, most likely the worse is going to be the coronary artery problem that we're having. And this is what we shown in the study, that patient who had the ED questionnaire, uh, the worse their erectile dysfunction performance, the higher their calcium score. So this project was specifically targeted to an underprivileged population in East Cleveland. So we know that cardiovascular disease is the number one killer for men in general, right? Strokes, heart attacks. But we also know that this incidence of cardiovascular disease mortality and morbidity is way higher and more amplified in people of color, Black men, underprivileged people. So this study that we did was specifically targeted toward these populations. So we went and chose areas based on their zip code and their annual salaries. And we went there and we partner with champion in their community who they trust, like the barber and the churches and the pastors. So the study was not done for the general population, right? It was done specifically to target people who needed the most. It's a good question. I think any tool that we can use to help us establish trust in healthcare or change the healthcare delivery system that we have could be helpful. So it could be helpful in two levels. One is specifically for sexual health. This is a very private concern, right? People do not usually talk about it. For men, it's a taboo unless it's severe. So it's a nice way of introduction to different urological condition, that this is a disease and we have treatment for that and we can help you. This is part one. But part two is we can use these questionnaire and these condition as the window to check other condition, like what we did with the cardiovascular system. So I think the more comprehensive we are in our screening and giving these patient questionnaire, explaining to them that health, everything in health is related. There is no isolated system. We're not dealing with silos, right? Erectile dysfunction is limited to the heart is limited to the kidneys. So everything is interconnected. And we need to broaden our projection and our way of thinking of these patients. We should not think about one condition or one disease at a time. We should think about the patient as a human, as a whole, as a health improvement project. So I think we should. Now, this is not where the guidelines are, right? Like if you look at the guidelines, different guidelines have a very specific requirement. But again, going back to the Cutler experiment that we have at Ahuja, creating a setting that's a bit different from your traditional old clinic space, helping the patient organize their healthcare, facilitate it, having a team that would follow up on scheduling and follow up and answering your question or call is a major added value to what we're trying to do.